Have you ever been recorded for assessment purposes? During my Bachelor's of Education, I was recorded multiple times while facilitating a class of 20 plus students. One recording was later viewed by peers and used as formative assessment, and the second was used as summative assessment. My instructors were located in Montreal, and I was in the Ottawa area. Time and cost restrictions made it difficult to have on-site observations. How does this tie in with health education? Video-based assessment can be used to address multiple issues in facilitating practical surgical training. Good afternoon, and thank you for joining our team for this presentation on video-based assessment. Why are you here? By the end of this presentation, we hope that you will be able to describe the function, assess the pros and cons, and define the characteristics, roles, and qualifications of educators in video-based assessment. We want you to understand its context of learning and assessment, explain the applicable theories and research and references, and to discuss new ideas, future implications of video-based assessment through virtual reality. The issues found in surgical training assessment are evaluation tools used to assess surgical skills in health education can be biased, recall-based, and subjective. Assessor efficiency and patient safety can be compromised by the need to evaluate the student performance while the procedure is being conducted. And lastly, assessments can be time-consuming and contribute to assessor and student burnout. To address these issues in health education assessment, we've undergone a research in video-based assessments. Video-based assessment is conducted by recording health education students performing simulations or operating on real patients. Recordings are edited and sent off to raters off-site to be evaluated asynchronously. This style of assessment can be situated under the constructivist learning theory and the competency-based approach after that. Our research has shown that video-based assessment can provide a more objective and reliable assessment. It can provide a more feasible and quality approach to patient safety and reduce the amount of time required by assessors to evaluate students. Thank you, and I will now pass it off to my colleague, Mark.
Hi everyone, I'm Mark. Now I'll dive into the description of how video-based assessment works. So this is any assessment using video recordings with asynchronous observation by the raters. The core concept is that you're using video and video editing technology to improve the quality of the assessment. Improve some efficiency as well. So for instance, we can watch remotely, not even necessarily in the same room or even in the same country. You can do it asynchronously at a different time, whatever time is most convenient for the assessor. And it can also be using additional features by virtue of the video editing components. So for instance, we can rewind, we can fast forward, we could zoom in just on key components, and we can completely cut out irrelevant portions. So for instance, do we need to wait for somebody to come into a room, sit down, get themselves set up? Or do we really only care about a key component of a procedure? Or we can also remove identifying personal features, which may be a source of rater bias. So for instance, taking away a component of gender or color of skin and focusing just on how someone's performing a task by zooming in just on that task portion. This is what it might look like. So up on the top left there, you could see camera 1, it's zoomed in. This examinee might be doing a procedural skill or a physical exam maneuver, and camera 1 could be zoomed in directly on that particular task, just seeing what the hands are doing. Camera 2 might be zoomed out and viewing the whole room and providing more of a global picture of what's going on. We may or may not choose to include an examiner in the room or do this completely by video asynchronously. These are probably most useful for any assessment where you want to watch somebody do something and in place of a direct observation. So for instance, performance or workplace-based assessments. We can do these for procedural skills, history or physical exam skills as might be in an OSCE, and also some non-technical skills, for instance, team communication in a crisis scenario. We could do this through simulated methods or even real-life recording. So it has been described in OR scenarios providing video feedback to a surgeon on how they're performing a technical skill. diving into some of the pros and cons here, and I'll leave for Alex to talk a bit more about the evidence behind it. So I've already talked about some of the practical natures of being asynchronous and remote, but it's also time efficient. So by having the assessor just do the components that's being scored and removing all the extra fluff. There's some reduced rater bias as a potential, which we've already talked about, and also quality assurance. So this is a way you can provide benchmarking for training as examiners review video in their own training, or to review how assessors are performing to ensure that we're providing high quality assessments. And then lastly, some of the cons here. So feasibility is the major one. You need equipment, there's a cost to set up, you need to maintain video quality, and it downloads some of the video editing demands to somebody other than the assessor, but it is work for somebody else. There may be some new editing bias that introduces, or new rater bias that's introduced by video editing. So for instance, is somebody watching a video performing the same assessment as somebody in the room? Or perhaps test anxiety on the part of the examinee might be a bit different if they know they're being recorded. And of course, personalized feedback can be more difficult if you're not actually getting it from the person in the room and only getting it delayed.
With regards to the characteristics, attributes, and qualifications of educators, we have to start by saying that well-designed video-assisted assessments provide the instructor with an opportunity to assess student learning, provide further guidance and instruction in a synchronous manner, and improve student learning. Now, for instructors to be able to take advantage of that, they should be able to perform content analysis at different levels of knowledge and learning, such as those presented by Bloom's taxonomy and Miller's pyramid. They should also be able to select procedures and activities that align with the content analysis. Select and design the video-assisted assessment based on the content as well, and they must be knowledgeable and skilled in statistical analysis. And that also involves non-parametrical ones because of the usual small sample that they are dealing with in such assessments. Educators must also be able to identify the important aspects and occurrences that take place in a video-assisted assessment, and then they should be able to make connections between their observations and what they expect from the students. To do so, they may use a pre-designed checklist, for example. They should also be able to use their knowledge of the context and their observations to draw conclusions. Educators should plan ahead and allocate time for completing the evaluations because they are time-consuming. Skills in using video software such as editing without missing relevant information is also really important to save time and increase efficiency. Furthermore, educators must be aware of personal biases that may arise during video system assessments. Finally, they should also have the ability to provide feedback in a timely manner. And finally, evaluator training has proven to be vital to promote the assessment's reliability. However, we still do not have adequate research or information regarding what sort of training they need and how it is performed. Now, with regards to the context of learning and assessment, we can either have this as a summative evaluation, which is an assessment of learning, or formative evaluation, which is an assessment as and for learning. So in summative evaluation, it is recommended that anonymity is maintained to increase objectivity, multiple rater favors reliability as well, and using a preset checklist is also recommended. Now, in a formative evaluation, it is preferable that educators who know the students well provide specific and personalized feedback. Educators could also review the footage with the students and act as mentors and coaches, and it is important to note that this requires time and dedication.
There are many benefits to video-assisted assessments like my colleagues have mentioned, one of which is that video-assisted assessments allows for a single trainee's performance to be assessed by more evaluators than in-person assessments, and consequently increases the reliability of assessments. This comes from a study that was done in 2005 by Williams and colleagues, where they've demonstrated by simply increasing the number of observations alone had a significant effect in improving the reliability of assessments. From a practical perspective, video-assisted assessments is able to increase evaluation quantity by having multiple evaluators examine the same clinical encounter or performance, but at the same time, because of the ease by which video-assisted assessments can be set up compared to traditional in-person assessments. This means that a trainee can now be assessed at a much higher frequency over the course of their training program compared to in-person assessments. Furthermore, video-assisted assessments increases trainee anonymity as well as increasing evaluation efficiency and collectively help to improve the validity and reliability of assessments. There's been studies that have shown that disclosing a resident's identity alone can alter significantly in terms of the score from evaluators. And this can be seen on the left-hand side in a study that was done among OBGYN residents. In addition to that, assisted assessments have been shown to be valid and reliable across multiple specialties, especially in surgical specialties where video capture is much more practical given the limitation of candidate patients for assessments. But even so, reliability and validity have been demonstrated in non-surgical specialties, particularly in those among general practitioners. From a practical perspective, the ways by which video-assisted assessments can maintain training anonymity includes capturing only necessary views, voice editing to prevent recognition of the trainee. In some studies, trainees have been video edited to have distortion of their face and recognizable features as well. As far as increasing efficiency evaluation, video-assisted assessment does reduce observation times. It is much more portable and relatively inexpensive, limits examiner burnouts, and eliminates the Hawthorne effect by which trainees may perform differently, knowing that they have a live audience. And last but not least, much of the principles behind competency-based medical education have a role for video-assisted assessments. In assessments of Miller's Pyramid, you can see that video-assisted assessment plays into a lot of the higher know-how and does stages of Miller's Pyramid of learning. And in addition to that, it's not difficult to appreciate how video-assisted assessment can play to much of the principles of optimizing assessment CBME as listed on the right.
In planning for the health professions education future, we recommend exploring video assessments with virtual reality. Simulation has gained momentum as a method of promoting experiential learning activities. It supports clinically relevant and practical teaching practices by tailoring learning and assessments to the needs, desires, expectations, and goals of our learners. Since adult health professionals prefer authentic, clinically relevant, and hands-on learning, we believe an important future step for HPE involves virtual reality video assessments. So what is virtual reality? VR is a powerful simulation tool that provides a totally immersive, dynamic, adaptive, and interactive experience. The use of a head-mounted display completely isolates the user's senses, which fosters a sense of presence to engage users in a realistic activity. Why is VR the future of video assessments? First, VR systems only require a headset and laptop combination, which are commercially available, relatively inexpensive, and have intuitive software design. This makes them easily accessible and allows users to access simulated clinical experiences in everyday practice. Further, by having access to clinical scenarios at our disposal, learning experiences can be repeated, which empowers learners to practice a specific learning objective until mastery is achieved. In addition, VR sims are enjoyable and provide psychological safety, which promote learner engagement and autonomy. This further reinforces a positive learning experience that is targeted to adult health professionals. From an institutional standpoint, the simplicity of the setup of VR allows simulation to be delivered at a reduced cost and with fewer resource implications. This involves a reduced physical footprint, faculty time, and training time for users and facilitators. From a learner-centered perspective, VR would allow for the creation and implementation of individualized simulation experiences that would meet specific needs of the learners and of the curriculum. Lastly, the flexibility, simplicity, and accessibility of VR in clinical simulation training would allow for large amounts of performance data to be collected, which would empower future learning and assessment practices in HPE. We believe VR video assessments will become the benchmark for clinical competency training and patient safety across healthcare systems. Furthermore, the future ability to standardize and score with VR will enable this assessment method to be utilized in many facets of healthcare, including virtual patient assessments, health program admission and recruitment programs, and continuing professional education and revalidation opportunities. Lastly, the flexibility, accessibility, and simplicity of VR video assessments should accelerate learning curves, which may shorten training timelines and consequently increase workforce to meet the evolving needs of our healthcare system. For more information on the use of VR in health professions education, we recommend the following 2 videos, journal articles, and book which have informed this part of our presentation. We want to thank you all for your time and attention for our presentation on the use of video assessments. We aim to describe the function, assess the pros and cons, define important characteristics, and elaborate learning and assessment theories to support the use of this technology in health professions education assessments. Lastly, we explored a future implication of video assessments through the use of virtual reality. We hope you have found this presentation to be informative and insightful. Thank you, and we look forward to your feedback.